Hi, and welcome to the lecture on Chapter 23, Bleeding. After you complete this chapter and the related coursework, you will understand the structure and function of the circulatory system, the significance and characteristics of bleeding, the importance of personal protective equipment when treating bleeding, the characteristics of external and internal bleeding, and how to conduct a patient assessment, as well as methodologies to control bleeding. According to the National EMS Education Standard Competencies, as we talked about before regarding trauma, the EMT will apply a fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. As we talk about bleeding, you will be able to recognize and manage bleeding, as well as understand the pathophysiology, assessment, and management of bleeding. Specifically to pathophysiology, you will apply fundamental knowledge of pathophysiology of respiration and perfusion to patient assessment and management. After management of the airway, recognizing bleeding and understanding how it affects the body are perhaps the most important skills you will learn as an EMT. Bleeding can be external and obvious or internal and hidden. Either way, it is a potentially dangerous situation and can cause weakness, shock, or death. The cardiovascular system circulates blood to all of the body's cells and tissues. Cells in the brain, spinal cord, and heart cannot tolerate a lack of blood for more than a few minutes. Cells in other organs, such as the lungs and kidneys, can survive for almost an hour. Skeletal muscle cells may survive for 2 hours in a state of inadequate perfusion. And without an adequate supply of blood, cells will begin to die, which leads to permanent loss of function or death. The cardiovascular system also functions to deliver oxygen and nutrients and carry away metabolic waste products. The three components of the cardiovascular system are the heart, the blood vessels, and the fluid. And this is just a great example of your cardiovascular system in its whole entirety. The heart functions as a pump, the vessels are your container, and your blood and bodily fluids are your fluid. The heart is a hollow muscular organ about the size of a clenched fist with its own regulatory system. Involuntary muscle under the control of the autonomic nervous system is how this works. You must have a rich and well-distributed blood supply, and you have to understand that the heart is actually a double pump. It works as two separate but paired pumps, the upper chamber of the atrium and the lower chamber of the ventricles, but also realize there's the left side and the right side. Blood leaves each chamber through a one-way valve. The right side of the heart receives oxygen-poor blood from the veins, and the left side of the heart supplies oxygen-rich blood to the arteries, and arteries carry blood away from the heart. The left ventricle is responsible for providing 100% of the body with oxygen-rich blood. As you can see here, great picture of the heart and the main vessels coming off the heart, and a great animation of the heart here. As you can see, the blue side is the deoxygenated blood returning and being pumped out to the lungs across the one-way valves. The red side is oxygenated blood going out to the body. There are 5 types of blood vessels. The first are arteries, which are small blood vessels that carry blood away from the heart. Then we have arterioles, which are even smaller, and they connect arteries to capillaries. The next level are capillaries, which are small tubes that link arterioles and venules. Venules are very small, thin-walled vessels that empty into veins, and veins are blood vessels that carry blood from the tissues to the heart. As blood flows out of the heart, it passes into the aorta, the largest artery of the body. Oxygen and nutrients easily pass from the capillaries into the cells, and waste and carbon dioxide diffuse from the cells into the capillaries. This transportation system allows the body to rid itself of waste products. At the arterial ends of the capillaries and in the arteries themselves are circular muscular walls. These walls constrict and dilate automatically under the control of the autonomic nervous system. When these muscles open, blood will pass into the capillaries in proximity to each cell of the surrounding tissue. When the muscles are closed, there is no capillary blood flow. In a healthy patient, all the vessels are never fully dilated or fully constricted at the same time. And here, just as I said, a picture of blood vessels and how this process works. Red blood cells are responsible for the transportation of oxygen to the cells and for transporting carbon dioxide away from the cells to the lungs. Then we also have white blood cells. You can see in the picture here, white blood cells are larger, red blood cells are smaller and slightly oddly shaped, and then platelets are also part of this function. Platelets are responsible for forming clots. A blood clot forms depending on one of the following principles, either blood stasis, a change in the vessel walls, or the blood's ability to clot. And then the final portion of blood is plasma. The autonomic nervous system is dynamic and constantly adapting to changing conditions to maintain homeostasis and perfusion. At times, the system fails to provide sufficient circulation for every body part to perform its normal function, and this condition is called hypoperfusion or shock. The autonomic nervous system monitors the body's needs from moment to moment and adjusts blood flow by adjusting vascular tone. It automatically redirects blood away from other organs to the heart, the brain, the lungs, and the kidneys in an emergency. Blunt force trauma can cause injury and significant bleeding that is unseen inside a body cavity or region. Significant amounts of blood loss, even without visible bleeding, cause hypoperfusion. In penetrating trauma, the patient may have only a small amount of bleeding that is visible. However, the patient may have sustained injury to internal organs that will produce significant bleeding that is unseen by you and may cause death very quickly. Perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygenation, nutrition, and waste removal. Part of this revolves around the speed of blood flow, and it must be fast enough to maintain adequate circulation. However, it must be slow enough to allow the cells time to exchange oxygen and nutrients for carbon dioxide and other waste products. Some tissues need a constant supply of blood while others can survive with very little. All organs and organ systems of the human body are dependent on adequate perfusion for proper functioning. Death of an organ system can quickly lead to death of the person. Emergency medical care is designed to support adequate perfusion until the patient arrives at the hospital. The heart requires a constant blood supply. The brain and spinal cord may last about 4 to 6 minutes without perfusion. The kidneys may survive for 45 minutes. Skeletal muscles may last up to 2 hours. The GI tract can tolerate slightly longer periods of inadequate perfusion. However, these times are based on a normal body temperature, and colder temperatures will lengthen survival times. Hemorrhage means bleeding. External bleeding is visible hemorrhage, and examples include things like nosebleed or any bleeding from open wounds. The significance of external bleeding: you have to understand that with serious external bleeding, it may be difficult to tell the amount of blood loss. Blood looks different on different surfaces. For example, if it's been absorbed in clothing versus diluted in water. You always need to attempt to determine how much blood your patient has lost. And the presentation and assessment of the patient will direct how you care and treat them. The body will not tolerate an acute blood loss of greater than 20% of the volume, and the typical adult has approximately 70 milliliters of blood per kilogram of body weight. Significant changes in vital signs may occur if the typical adult loses more than 1 liter, or the equivalent of about 2 pints of blood. The heart rate will increase, the respiratory rate will increase, and blood pressure will begin to fall. Because infants and children have less blood volume to begin with, the same effect is seen with smaller amounts of blood loss. How well a patient compensates for blood loss is related to how rapidly they bleed. An adult can comfortably donate 1 unit, or about 500 milliliters of blood, over a period of 15 to 20 minutes. If a similar blood loss occurs in a much shorter period of time, the person may rapidly develop hypovolemic shock, which is a condition where low blood volume results in inadequate perfusion and even death. Some of the things we must consider in the pre-hospital setting include the age and pre-existing health of your patient. You should consider bleeding to be serious if the following conditions are present. There is a significant mechanism of injury. The patient has a poor general appearance and is calm. There are signs and symptoms of shock present. There is significant loss of blood. There was rapid blood loss. Bleeding is uncontrollable. Blood loss is an extremely serious problem that demands immediate attention as soon as airway and breathing are addressed. Some of the characteristics of external bleeding. Injuries and some illnesses can disrupt blood vessels and cause bleeding. First, we'll talk about arterial bleeding. The pressure causes blood to spurt and make bleeding difficult to control. It's typically brighter red because it's high in oxygen content, and it spurts in time with the heartbeat or the pulse. It decreases as the amount of blood circulating in the body drops and blood pressure drops. The second type of bleeding we'll talk about is venous bleeding. It's dark red because it's low in oxygen content. It flows slowly or severely depending on the size of the vein. It does not spurt, and it is easier to manage, and it can be profuse and life-threatening. It is more likely to clot spontaneously than an arterial bleed. The final is capillary bleeding. Bleeding from damaged capillary vessels happens with capillary bleeding. It's dark red, it oozes steadily but slowly, and it's more likely to clot spontaneously than an arterial bleed. As you can see on your screen, there are the three examples of blood loss: capillary, venous, and arterial. The clotting process is important for the EMT to understand. Bleeding tends to stop rather quickly, within about 10 minutes, in response to internal mechanisms and air exposure. When a person is cut, blood flows rapidly from the open vessel. Then the cut ends of the vessel will begin to narrow, and we call this vasoconstriction, which reduces the bleeding amount. Then a clot forms, and this is called coagulation. You have to remember that if a clot does not form, bleeding will not stop unless the injured vessel is completely cut off from the main blood supply. Despite the efficiency of the clotting system, it may fail in certain situations. Some of these include movement, certain medications, removal of bandages, the external environment, body temperature, and severe injury. Something to be aware of is a disease process called hemophilia. This is where the patient lacks one or more of the blood clotting factors. There are several forms, and most are hereditary and some are severe. Bleeding may occur spontaneously, and when in these patients, all injuries, no matter how trivial, are potentially serious. Patients need to be transported immediately if they have this condition. Internal bleeding is any bleeding in a cavity or space inside the body. It can be very serious, yet with no outward signs. Injury or damage to internal organs commonly results in extensive internal bleeding, which can cause hypovolemic shock. Some possible conditions causing internal bleeding include stomach ulcers, lacerated liver, a ruptured spleen, broken bones, especially the ribs or the femur, and pelvic fractures. The mechanism of injury for internal bleeding. You need to realize that if there is a high energy mechanism of injury, this should increase your index of suspicion for the possibility of your patient experiencing severe unseen injuries. Internal bleeding is possible whenever the mechanism suggests that severe forces had an effect on the body, such as blunt or penetrating trauma. We use the mnemonic DCAP-BTLS to assess for signs of injury. This stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. Bleeding is not always a result of trauma. Some of the non-traumatic causes that we may see include bleeding ulcers, colon bleeding, ruptured ectopic pregnancies, and aneurysms. These signs are frequent but not always present, and they include tenderness of the abdomen, guarding, rigidity, pain, and distension. In older patients, the signs include dizziness, faintness, and weakness. If your patient has ulcers or other GI problems, this may cause them to vomit blood or have bloody diarrhea or urine. It is not as important for you to know the specific organ involved as it is to recognize that the patient is in shock and for you to treat them appropriately. Some of the signs and symptoms of internal bleeding. Pain, which is the most common. swelling in the area where the bleeding is occurring, distension, bruising, a contusion or ecchymosis, most commonly in head, extremity, pelvic, and abdominal injuries, dyspnea, tachycardia, and hypotension, specifically in chest trauma, hematoma. This is a mass of blood in the soft tissues beneath the skin, bleeding from any body opening, such as bright red bleeding from the mouth or the rectum, hematuria, which is blood in the urine, or non-menstrual vaginal bleeding. Hematemesis, or vomited blood, can be bright red or dark red, and it may look like coffee grounds. Melena is a black, foul-smelling, tarry stool that has digested blood in it. Hemoptysis is bright red blood that your patient coughs up. Some of the other things to look for are pain, tenderness, bruising, guarding or swelling, which indicates a possible closed fracture. You have to remember that broken ribs or bruises over the lower part of the chest or a rigid distended abdomen can indicate possibility of a lacerated spleen or liver. We look for signs of hypoperfusion, such as change in mental status, anxiety, restlessness, or combativeness, weakness, faintness, or dizziness on standing, and changes in skin color or pallor. Later signs of hypoperfusion suggesting internal bleeding include tachycardia, weakness, fainting or dizziness at rest, thirst, nausea and vomiting, cold, moist skin, and shallow, rapid breathing. Dull eyes, slightly dilated pupils that are slow to respond to light, a capillary refill of more than 2 seconds in children and infants, a weak, rapid, thready pulse, a decreasing blood pressure, and altered levels of consciousness. Patient assessment for external and internal bleeding. The steps are always the same, as I've said before. Size up the scene, perform a primary assessment, take your history, perform a secondary assessment, and reassess. For scene safety, you must be alert to potential hazards. At vehicle crashes, ensure the absence of leaking fuel and energized electrical lines. In violent incidents, make sure the police are on scene. And follow standard precautions. You want to check mechanism of injury or nature of illness. This must be determined. You need to consider the need for spinal stabilization or additional resources for patient treatment and consider factors such as the weather and the environment. Primary assessment. Do not be distracted from identifying life threats. You need to form a general impression of your patient. You need to note important indicators that may alert you to the seriousness of your patient's condition. And you must be aware of obvious signs of injury and distress, such as a facial grimace. Determine your patient's sex and age and assess for skin color and determine level of consciousness using AVPU. Assess for airway and breathing. You need to consider spinal stabilization, ensure that the airway is patent, look for signs of adequate breathing, listen to breath sounds, and provide high-flow oxygen or potentially assist ventilations with a BVM device or a non-rebreather for the high-flow oxygen. Assess circulation. You must assess rate and quality of the pulse, assess skin color, temperature, and condition, check capillary refill, and control all signs of external bleeding. You also need to treat for shock by applying oxygen, improving circulation, and maintaining a normal body temperature. Make your transport decision. Assessment of ABCs and life threats will determine transport priority. Patients who may have significant bleeding will quickly become unstable. Some signs that they need rapid transport include tachycardia, tachypnea, low blood pressure, a weak pulse, and clammy skin. This animation is showing you tachycardia. You can actually count the heart rate and see how fast the heart is beating, and it will be over 100 beats per minute. Take your history. You need to investigate the chief complaint. Look for signs or symptoms or other injuries due to your MOI or your NOI or both. With severe bleeding, you may have identified it in the primary assessment and you need to begin treatment and rapid transport to the definitive care facility. Note obvious signs of internal bleeding and look more carefully in this step. In a responsive trauma patient who has an isolated injury with a limited mechanism, consider a focused assessment before assessing vital signs and obtaining a history. Assess the entire patient, looking for fractures and other problems, and determine if there are any pre-existing illnesses. Here you can see mechanism of injury indicators of internal bleeding. Please review these. This is a great study guide for you. Take your sample history. Ask the patient about taking blood thinning medications. If they're unresponsive, obtain history from medical alert tags or bystanders. Observe for signs and symptoms of shock and determine how much blood your patient has lost. Secondary assessment. Record vital signs. Complete a focused assessment of pain. Attach appropriate monitoring devices. And if your patient is critically injured or you have a short transport time, you may not actually do a secondary assessment. Perform a physical exam. This needs to include a systematic full-body scan where you assess the respiratory system, assess the airway for patency, determine the rate and quality of respirations, and in the neck, observe for distended neck veins or a deviated trachea. In the chest, you're going to check for paradoxical movement of the chest wall and bilateral breath sounds. Assess the cardiovascular system, specifically rate and quality of pulses. Assess the neurologic system to formulate baseline data to guide further decisions. Determine the level of consciousness. Examine pupil size and reactivity, and assess motor and sensory response. Also assess the musculoskeletal system. You're going to assess all anatomic regions, including the head, looking for things like raccoon's eyes, battle signs, or drainage of blood or fluid from the ears and nose. The abdomen, you're going to palpate all four quadrants for tenderness or rigidity, and the extremities. You're going to record pulse, motor, and sensory function in all four extremities. Vital signs. Assess your baseline vital signs to observe the changes that may occur during treatment. A systolic blood pressure of less than 100 millimeters of mercury with a weak rapid pulse should suggest the presence of hypoperfusion. Cool, moist skin that is pale or gray is an important sign. Monitoring devices. These quantify oxygenation and circulatory status. You're going to assess the patient's blood pressure with a blood pressure cuff and stethoscope manually before you use automatic blood pressure devices to establish your baseline. Use pulse oximetry to evaluate the effectiveness of oxygenation. Reassessment. Reassess your patient, especially in the areas that showed abnormal findings during your primary assessment. Signs and symptoms of internal bleeding are often slow to present, and these may be missed otherwise. Children especially will compensate well for blood loss and then crash very quickly. You need to assess the effectiveness of any interventions and treatments provided to the patient. Vital signs show how well your patient is doing internally, and in severe cases, you're going to assess every 5 minutes. Is the patient's airway still patent and breathing still adequate? And is the oxygen helping the patient to breathe easier? Is your treatment for shock resulting in better perfusion of the vital organs? And is the bandage controlling bleeding? For interventions, provide high-flow oxygen. Provide treatment for shock if applicable and transport rapidly. If internal bleeding is suspected, apply high-flow oxygen via a non-rebreather mask and provide rapid transport. Do not delay transport of a patient to complete an assessment. Regarding your communications and documentation, you must recognize, estimate, and report the amount of blood loss and how rapidly or over what period of time this occurred. Communicate all relevant information to the staff at the receiving facility. And with a patient having internal bleeding, describe the mechanism or nature of the illness and the signs and symptoms. Communicate your findings as well as your interventions and document all injuries, the care you provided, and the patient's response. Emergency medical care regarding external bleeding. The first and most important thing is to follow standard precautions. Wear gloves, eye protection, and possibly a mask or gown. Make sure that the patient has an open airway and is breathing adequately, and provide high-flow oxygen. There are several methods available to control external bleeding: direct, even pressure and elevation, pressure dressings or splints, tourniquets. Sometimes it's important to remember that you may combine methods, and that may be the most useful. Direct pressure. It is the most effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation to occur. Apply pressure with your gloved fingertip or hand over the top of a sterile dressing. If an object is protruding from the wound, apply bulky dressings to stabilize the object in place and apply pressure the best way you may do so. Never remove an impaled object from a wound unless it's interrupting airway and breathing. You need to hold uninterrupted pressure for at least 5 minutes and follow the steps in Skill Drill 23-1 to control external bleeding with direct pressure. Elevation. Elevate a bleeding extremity by as little as 6 inches while applying direct pressure. Never elevate an open fracture to control bleeding. Fractures can be elevated after you splint them, and splinting may also help control the bleeding. Pressure dressings. Firmly wrap a sterile self-adhering roller bandage around the entire wound. You may use 4x4 sterile gauze pads for small wounds and sterile universal dressings for larger wounds. Cover the entire dressing above and below the wound, stretch the bandage tight enough to control bleeding, and you should still be able to palpate a distal pulse on the injured extremity after you apply the dressing if you were able to do so before. Do not remove the dressing until a physician has evaluated the patient. Apply additional manual pressure through the dressing, and if necessary, add more dressings over the first. Secure dressings with a second, tighter roller bandage. Bleeding will almost always stop when the pressure of the dressing exceeds arterial pressure. If direct pressure fails, apply a tourniquet above the level of bleeding. If a tourniquet is deemed necessary, it should be applied quickly and not released until a physician is present. The tourniquet is useful if a patient has substantial bleeding from an extremity injury below the axilla or groin, and you will follow the steps in Skill Drill 23-2 to apply a commercial tourniquet. Whenever you apply a tourniquet, make sure you observe the following precautions. Do not apply it directly over a joint. Make sure that it is tightened securely. Never use wire, rope, a belt, or any other narrow material because it could cut into the skin. And use wide padding under the tourniquet if possible to protect the tissues and help with arterial compression. Never cover a tourniquet with a bandage, and do not loosen the tourniquet after you have applied it. Splints can control internal or external bleeding associated with severe injuries. They can stabilize fractures, and they act like a pressure dressing applied to an entire extremity rather than to a small local area. They're commonly referred to as soft splints or pressure splints. Once the splint is applied, monitor circulation in the distal extremity and use only approved clean or disposable valve stems when orally inflating air splints. Rigid splints can help stabilize fractures, reduce pain, prevent further damage to soft tissue injuries, and remember, once you apply it, monitor circulation in the distal extremity. Traction splints are designed to stabilize femur fractures. When the EMT pulls traction to the ankle, counter-traction is applied to the ischium and groin. This reduces the thigh muscle spasms, prevents one end of the fracture from impacting or overriding the other, and you pad these areas well to prevent applying excessive pressure to the soft tissue of the pelvis. Once you apply a traction splint, monitor circulation in the distal extremity. Bleeding from the nose, mouth, and ears. Several conditions can result in bleeding from the face, especially the nose, ears, and mouth. Some of these include a skull fracture, facial injuries including those caused by a direct blow to the nose, sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa, or other abnormalities, high blood pressure, bleeding disorders, and digital trauma, such as nose picking. A nosebleed or epistaxis is a common emergency encountered in the pre-hospital setting. Occasionally, it can cause enough blood loss to lead to shock. The blood you see may only be a small part of the total blood loss because much of the blood may pass down the throat into the stomach as the patient swallows. A person who swallows a large amount of blood may become nauseated and start vomiting, and you may confuse this with signs of internal bleeding. Most non-traumatic nosebleeds occur from sites in the septum, the tissue dividing the nostrils. Generally, this can be handled effectively by pinching the nostrils together, and you will follow the steps in Skill Drill 23-3 to control epistaxis. Bleeding from the nose or ears following a head injury may be indicative of a skull fracture. It may be difficult to control, and you should not attempt to stop the blood flow. By applying excessive pressure to the injury, this may force the blood leaking through the ear or nose to collect within the head. This could increase the pressure on the brain and possibly cause permanent damage. If you suspect a skull fracture, Loosely cover the bleeding site with a sterile gauze pad to collect the blood and help keep contaminants away. Apply light compression by wrapping the dressing loosely around the head, and remember that a target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebrospinal fluid. Emergency medical care for internal bleeding. Controlling internal bleeding or bleeding from major organs usually requires surgery or other hospital procedures. You must keep your patient calm, reassured, and as still and quiet as possible. If spinal injury is not suspected, place the patient in the shock position and provide high-flow oxygen. Maintain their body temperature, splint injured extremities, generally using an air splint, and never use a tourniquet to control the bleeding from closed internal soft tissue swelling and trauma. Follow the steps in Skill Drill 23-4 to care for patients who are experiencing internal bleeding. In summary, perfusion is the circulation of blood in adequate amounts to meet each cell's current needs for oxygen, nutrients, and waste removal. The three arms of the perfusion triad must be functioning to meet this demand. This includes a working pump, the heart, a set of intact pipes, the vessels, and proper fluid volume, which is enough oxygen-carrying blood. Hypoperfusion, or shock, occurs when one or more of these three arms are not working properly and the cardiovascular system fails to provide adequate perfusion. Both internal and external bleeding can cause shock, and you must know how to recognize and control both. The methods of bleeding control in order are direct local pressure, elevation, pressure dressing, tourniquet, and splinting. Bleeding from the nose, ears, or mouth may result from a skull fracture. Other causes include high blood pressure and sinus infection. You need to evaluate your MOI and consider the more serious problem of skull fracture. Bleeding around the face always presents a risk for airway obstruction or aspiration. You need to maintain a clear airway by positioning your patient appropriately and using suction when indicated. If bleeding is present at the nose and a skull fracture is suspected, place a gauze pad loosely under the nose. If bleeding from the nose is present and a skull fracture is not suspected, pinch both nostrils together for 15 minutes. If the patient is awake and has a patent airway, place a gauze pad inside the upper lip against the gum. Any patient you suspect of having internal bleeding or significant external bleeding should be provided proper prompt transport. If the mechanism of injury is significant, be alert to signs of unseen bleeding in the chest or abdomen. These signs include serious bruising or symptoms such as complaints of difficulty breathing or abdominal pain. The signs of serious internal bleeding include vomiting blood, black tarry stools, coughing up blood, a distended abdomen, and broken ribs. Thanks for your attention, and as I said, any questions, please refer to your classroom instructor.